You are listening to the Journal of Rheumatology's Editor's Picks with Dr. Earl Silverman, Editor-in-Chief.
Hello again, this is Earl Silverman, Editor-in-Chief of the Journal of Rheumatology. Welcome you to the July 2025 edition of Editor's Summary. This month's featured interview is by Associate Editor Dr. Proton Rahman, who interviews Drs. Gonu Kok and Mark Kok discussing their article titled The Effect of Early Attainment of Minimal Disease Activity on Radiographic Outcomes, a real-world longitudinal study in psoriatic arthritis.
Can you provide some background on the rationale behind your study and just the major results that you are reporting?
Thank you for Dr. Proton Rahman, and also thank you for us to give us this opportunity to talk about our current results about our studies. And maybe I'll start with the DAPAR cohort study, because DAPAR is a really good established real-world longitudinal cohort which contains the newly diagnosed psoriatic arthritis patients. And actually the real rationale about background about this article, this is the follow-up study of work within the DAPAR cohort. We already defined the minimal disease activity within the first year after PSA diagnosis, and also we already show that this situation was strongly associated with the better long-term outcomes according to patient-reported outcomes, and including the improvements in pain, also fatigue, physical function, and mental well-being. And that is highlighted how early clinical control in the significantly improves the patient quality of life. But this study did not address the structural damage, and structural damage is a really key long-term outcome for the psoriatic arthritis. And also it is a very big question in the MDA research agenda, and that is why we designed this study by using our previous definitions. And in our study, we stratified the patients into 3 groups: the MDA, sustained MDA group, non-sustained MDA group, and the no MDA group. Sustained MDA group contains the patient who achieved the MDA within the first year, at least at month 9 and 12. And no MDA group is contain the patients who did not achieve within the first year MDA. And also we have the 284 patients in our studies, and we focused mostly about the oligo and polyarticular psoriatic arthritis patients, because we use the radiographic progression data, modified total sharpened score, and which is the mostly assessed the only peripheral joints. That is why we use only oligo and polyarthritic patients. And according to our results, we find nearly 40% of patients falling to MDA achievement within the first year. And at baseline, these patients, this no MDA group, had the higher proportion of women, and also they have the higher tender joint count again at baseline, and enthusiast counts, this no MDA group. And also they have the worst baseline patient-reported outcomes, which we already showed in our previous results. And also they also have a bit slightly higher modified total sharpened score at baseline. And when we assess as a longitudinal way over the radiographic changes over time, we use linear mixed model to find these solutions. And we found that who did not achieve MDA in the first year, which are the no MDA group, experienced significantly greater radiographic changes over the time than the other 2 groups.
I hope you enjoyed listening to part of Dr. Rahman's interview with the authors of their paper titled The Effect of Early Attainment of Minimal Disease Activity on Radiographic Outcomes, a real-world longitudinal cohort study in psoriatic arthritis, and that you will listen to the full interview, which is available at our website, www.jrheum.org, and on our YouTube channel. Now moving on to the other articles in the July 2025 edition. This month, we have an expert review by Dr. Shihata and D'Souza titled Expert Review, Conducting a High-Quality Systematic Review. Self-efficacy is important in the care of patients with chronic diseases, as higher levels of self-efficacy have been associated with greater goal achievement, acceptance of the illness, problem-focused coping, and quality of life. In their study titled Development of an Application for Self-Monitoring to Empower Patients with Rheumatoid Arthritis, MYRA, or MyRA, Reumann and co-authors used focus groups and developed a web-based self-monitoring tool with the goal to improve empowerment of patients with RA. In their paper, the authors review the process that led to the development of their web-based self-monitoring application, MyRA. MyRA uses an avatar to ask patients to score 6 domains of pain, fatigue, physical function, mental well-being, social participation, and quality of life. The avatar uses graphic displays, a diary, functionality, and practical tips. This exciting preliminary study requires further confirmative studies to validate its usability and effectiveness in empowering patients with RA. In the general population, it has been shown that low socioeconomic status has been associated with higher mortality post-myocardial infarction in U.S. Medicare beneficiaries, and low income has been associated with an increased rehospitalization. In their study titled Rural Dwelling Patients with Rheumatoid Arthritis and Risk of Myocardial Infarction Hospitalization, an observational study using the National Inpatient Sample, Singh and Chandrupathia, used the 2016 to 2019 U.S. National Inpatient Sample data to determine if there is a rural to urban and income-related disparity in the incidence and outcome of myocardial infarction hospitalization in patients with RA. The crude rate of MI hospitalizations per 100,000 area-specific hospitalizations in people with RA was significantly higher for rural versus urban residents. In multivariable adjusted models that compared urban residents, rural residing residents with RA, in multivariable adjusted models compared to urban residents, rural residents with RA were almost twice as likely to be hospitalized with an MI. Regarding income, the two highest income quartiles were significantly associated with lower odds of MI hospitalization as compared to patients in the lower quartile. As compared to urban residents, rural residents had minimal or no difference in post-MI healthcare utilization. This study again emphasizes healthcare disparities related to social economic factors. In 2024, the European Alliance of Associations for Rheumatology, EULAR, and the Pediatric Rheumatology European Society Press jointly proposed recommendations for the diagnosis and management of still disease with the goal of a drug-free remission. In their study titled Achievement and Usefulness of Intermittent Treatment Targets for Still Disease, proposed by the European Alliance of Associations for Rheumatology and Pediatric Rheumatology European Society, TAMI and co-authors examined the feasibility of meeting the intermediate treatment targets at day 7, 4 weeks, 3 months, and 6 months. in patients with adult onset Still's disease. The recommended treatment targets were achieved in 67.2% of the 62 patients at day 7, 61% at week 4, 3.3% at month 3, and 1.7% at month 6. The failure to achieve the treatment targets at months 3 and 6 was mainly due to corticosteroid uses, as clinically active disease was greater than 60% at both time periods. Clinically inactive disease was associated with a lower recurrence rate within 3 years, while age greater than or equal to 65 years was associated with more recurrences. The authors showed that the EULAR Press intermediate treatment targets for Still disease are useful targets for the management of adult onset Still disease. Knowledge and awareness of disease manifestations are important factors in order to make an accurate diagnosis and appropriate referral. In their paper titled Knowledge, Awareness, and Attitudes Regarding Axial Spondyloarthritis Among Non-Rheumatology Physicians in the United States, Odell and co-authors surveyed non-rheumatology physicians who saw patients with low back pain in order to assess their knowledge, awareness, and attitudes of axial spondyloarthritis. They sent an online questionnaire to family, internal medicine physician, spine surgery and orthopedic physicians, pain management, and physical medicine rehabilitation physicians, and used rheumatologists as a comparator group. 750 physicians completed the survey, which represented a response rate of 24%. The authors found that the majority of the non-rheumatology respondents were familiar with inflammatory back pain, and that 87% could identify greater than 4 of the 8 inflammatory back pain items, but that only 40% routinely assessed inflammatory back pain in practice. The non-rheumatologists, as compared to the rheumatologists, screened these patients with chronic back pain for axial spondyloarthritis, risk factors 50% or less, but ordered ANA and RF significantly more than the rheumatologists, but CRP and HLA-B27 were ordered significantly less. Only 50% of the non-rheumatologists correctly answered X-ray or SI pelvis as correct initial imaging test, and only 37% correctly selected MRI pelvis as the next imaging test. They found that non-familiarity with the term axial spondyloarthritis and non-radiographic axial spondyloarthritis was reported in only 11% and 35% of the non-rheumatologists, respectively. And, as may be expected, the non-rheumatologists less often than the rheumatologists considered axial SPA or AS as a possible diagnosis in patients with chronic low back pain. Formal referral guidelines and improved education were endorsed by both groups to help reduce the diagnostic delay of axial spondyloarthritis. Psoriatic arthritis is associated with metabolic and cardiovascular disease while treatment with everolimus, a selective phosphodiesterase 4 inhibitor, may be associated with weight loss and other cardiometabolic effects. Therefore, Hans Ladar and co-authors in their multi-center study titled Cardiometabolic Effects of Apremilast in Patients with Psoriatic Arthritis, a prospective cohort study, studied 44 patients with PSA for up to 12 months and had measurements at baseline, 6 months and 12 months. The mean age of the PSA cohort was 56 years, median BMI was 28, and the mean weight was 87 kilos. Measurements were available at baseline in 44 patients, week 26 and 22, and only 15 in week 52. The authors found significantly reductions in total fat and android fat in the patients, while lean mass remained stable over time. There was a small reduction in blood pressure, while lipids, cardiointermedial thickness, and glucose levels did not change. Hopefully, this preliminary study will lead to studies with more patients and more direct measurements of cardio risk factors in PSA patients treated with apremilast. The 2021 American College of Rheumatology Clinical Practice Guidelines recommended initiation of therapy with tocilizumab in all patients with newly diagnosed giant cell arteritis. In their paper titled Delays in Tocilizumab Impacts Therapy for Patients with Giant Cell Arteritis in the United States, Federman Jimenez and co-authors used medical records from the University of Washington Medical Center, Washington, USA, and found that 86% of patients that were diagnosed in their GCA Fast Track Clinic over a 7-year period had a mean time between the request for tocilizumab and the administration of the first dose at 43 days. The mean time between request and insurance approval was 17 days, and the mean time between medication approval and medication start was 30 days. They found differences in the times of the above measurements when used 2-year periods since its approval in 2017. In an accompanying editorial, Zuha Zhang and Liam Barra from the Schulich School of Medicine and Dentistry, Western University, London, Canada, reviewed the approval process for tocilizumab for GCA in Canada and compared this to the U.S. study by Federman Jimenez. They review the potential reasons for the delays and go on to point out that both the strengths and limitations of the study, which includes the potential impact in the delay of diagnosis of initial tocilizumab therapy. Fatigue and sleep disturbances frequently occur in patients shortly after their diagnosis of polymyalgia rheumatica. In their study titled More Than Pain and Stiffness, Persistent Fatigue and Sleep Disturbance in Polymyalgia Rheumatica, Liang and co-authors examined pain and fatigue serially in 36 patients with PMR at their initial diagnosis, then 3 months after beginning corticosteroid therapy, and again 18 months later. They found that significantly more PMR patients, as compared to controls, suffered fatigue at at 36% and 35% at baseline and follow-up, respectively, while the control subjects had fatigue in only 3% of them at both time points. Fatigue adversely affected physical and mental function, with adverse effects in activities of daily living and in emotional well-being. Features associated with fatigue included higher adiposity, psychological comorbidity, and PMR disease activity. In contrast to fatigue, poor sleep quality was more frequently seen in PMR patients than controls at 77.1% and 83.9% at baseline and follow-up, respectively, versus 56.3% of controls at both time points. There was no association with fatigue and poor sleep. In an accompanying editorial titled Understanding Fatigue and Sleep Disturbances in Polymyalgia Rheumatica, Redefining the Patient Experience and Opportunities for Intervention, Patricia Harkins and Sebastian Satui from the University of Dublin, Ireland, and the University of Pittsburgh, USA, emphasized that not only fatigue is a significant problem in patients with PMR, but also, importantly, the fatigue was persistent 2 years after treatment, despite recent advances in therapy. Frequently, patients with systemic sclerosis may have features of another connective tissue disease, and these patients are best categorized as having an overlap syndrome. In their study titled Characteristics of Overlap Syndrome in a Large Cohort of Brazilian Patients with Systemic Sclerosis, a retrospective analysis, Gamma and co-authors found that 11.6% of their cohort of patients who had met the 2013 ACR-ULAR criteria for systemic sclerosis had an overlap syndrome, as they also met diagnostic classification criteria for another rheumatic disease. This was SLE in 29.7%, Sjogren disease in 26.4%, rheumatoid arthritis in 24.2%, and an inflammatory myopathy in 19.8%. Patients with overlap syndrome tended to be younger, with an earlier age at onset and diagnosis than those without. Compared to the total patient cohort, patients with an overlap syndrome had a higher prevalence of musculoskeletal symptoms, neoplasias, and Sicca syndrome, but a lower frequency of pulmonary hypertension. As may be expected, the autoantibody profiles differed between the two groups. However, no worse prognosis was observed. The frequency of the overlap syndrome in this study was similar to that found in other studies. However, other studies found the predominance of patients with an overlap with an idiopathic inflammatory myopathy, while in this study there was no clear predominance of any rheumatic disease. In the accompanying editorial titled The Nuances of Shared Autoimmunity and the Singularity of Mixed Connective Tissue Disease, Tania Rodriguez Reina from the Instituto Nacional de Ciencias Medicina y Nutrición, Salvador Zuberin, Mexico City, Mexico, highlights the importance of using accepted classification criteria for the diagnosis of the rheumatic disease, and that it may be very difficult to have a patient with systemic sclerosis and mixed connective tissue disease when overlap criteria are adhered to. The editorial points out that the Brazilian population may have its own unique ethnic mixture of white, Native American, and African descent populations that likely influence the frequency of clinical and serological manifestation as well as prognosis. Specialist physician remuneration has been demonstrated to influence physician practices and thereby may affect access to health services and quality of care. In their study titled Inequities in Fee-for-Service Remuneration Affecting Rheumatologists and Patient-Centered Care Across Canada, an environmental scan, Kwok and co-authors found inequalities for reimbursement to rheumatologists across Canada. Reimbursement for new consultation varied between $153.51 to $239.57 Canadian dollars. And similarly, the fees for follow-up differed with a range of $65 to $131. Across Canada, virtual care was funded generally at a lower rate than the same visit for an in-person care. Multiple or interdisciplinary team-based care were rarely funded, as only 20% of the provinces had a dedicated billing code to fund nursing co-managed care. 20% allowed for payment of professional service for musculoskeletal ultrasound by a non-radiologist. And again, 20% of the provinces reimbursed for monitoring of immunosuppressive therapy. Furthermore, there was a large variation for reimbursement for joint injection or aspiration and arthrocentesis across the provinces. It would be interesting to see if the variation in remuneration altered patient care, and if there are differences that are present in other countries which have multiple jurisdictions that set physician fees. It is possible that the widespread availability of ANA multiplex testing may lead to the overutilization of this testing, and its use may not be symptom-guided. In their paper titled Antinuclear Antibody Multiplex Utilization Across a Large Federal Health Hospital System, an investigation of ordering practice and rheumatologic outcomes, Patel and co-authors examined the use of this test in 2,499 patients without a previously diagnosed autoimmune disease, and found that only 3% of these individuals tested positive in the ANA multiplex assay and were subsequently diagnosed with a new ARD. Of the 74 patients who were diagnosed with a new ARD, 50% were positive in the multiplex group and 50% were negative. 97% of the ordered ANA multiplex testing did not lead to a diagnosis of an autoimmune rheumatic disease. However, if the test was ordered by a rheumatologist, the individual who was tested was 10.7 times more likely to have an ARD as compared to the total cohort. This month's Panorama 360 Degrees of Rheumatology article is titled the boutonniere deformity and piano key sign depicted in a 12th century Chinese painting illustrates a painting from the Song dynasty. There are 2 images in Rheumatology this month. The first describes a 67-year-old woman with EGPA and eosinophilic cellulitis, and is titled Skin Eruption and Nerve Impairment Eosinophil Activation Link. Second article is titled Systematic Granulomatosis with Polyangiitis Presenting with Bilateral Renal Masses, and describes a 65-year-old woman who presented with bilateral hypoenhancing renal masses on CT as a manifestation of her GPA renal involvement. The research letter this month is titled Acrocyanosis After Immunotherapy, Vasculitis or Vasculopathy, New Iatrogenic Disease Case Series from Canreal. In this report, the authors describe 6 new cases and review the 8 previously described cases of acral digital acrocyanosis following cancer treatment with immune checkpoint inhibitors. There is 1 case report titled A Frameship Mutation of NLRP12 in a patient with chronic recurrent multifocal osteomyelitis, and it has a graphic abstract on how the described mutation in the NLRP12 gene could lead to the patient's phenotype. This month, we had the pleasure to publish a review of the talk Dr. Daphne Gladman gave for the invited Dunlop lectureship. Her talk was titled The Road to a New Horizon in Psoriatic Arthritis, in which she reviews the history of psoriatic arthritis, important milestones in managing PSA care, the importance of comorbidity in patients' outcome, unmet patients' needs, and proposes future directions for research to improve patient care and outcome. I want to thank you for listening to this podcast. I encourage you to read the complete articles, which may be of interest to you in the July 2025 edition of the Journal of Rheumatology. These articles are available in either the print or online edition, which is available at www.jrheum.org. And please watch the interviews of the authors of the highlighted article, not only of this month, but from previous months if you have missed them. They are available on our website and on our YouTube channel. If you have any comments or questions of any of the articles in the Journal of Rheumatology, please send them to manuscripts@jrheum.com. And I encourage you to join me for the August 2025 edition of Editor's Summary. And thank you for listening.